Ortho and pedo do go very hand in hand. Child usually comes to us first at a younger age. So if we identify the root cause of a problem early on, we can take preventive measures so that later on in life, the ortho treatment required may be eliminated or can be at least reduced in the timeline or time structure.
Yeah. Patient might not require extraction eventually. Maybe if you're not from that city, don't try to settle here. Try to go to a second tier city or your hometown where you know people.
Right.
It's easier to set up practice around an area where you know everyone.
I myself got my aligners done with him. So being a dentist, I trust him that much that I got my treatment.
Better than that.
So yeah.
Definitely. You should know how to market yourself.
Yeah.
Oh yeah.
Marketing, Instagram
even
presence.
if you know the best of the best procedures and if you can't market
yourself. That is very important now. We need to know how to market ourselves.
How do you plan to?
Hopefully this podcast.
Hi everyone, welcome back to the MADtherapy Sessions podcast. Our guests for today are Dr. Komal Nanavati, who's a consulting pediatric dentist in and around Mumbai, and Dr. Akram Shaikh, who's a consulting orthodontist and has his own practice in Mumbai. For the audio podcast on Spotify and YouTube Music, I will be providing links in the description down below. Enjoy the episode. The funny part is I have never met Komal during BDS days.
Oh yeah.
Inspired कि अपन सब से नहीं, I think once
ट्रेन में मिले होंगे कभी?
नहीं, ट्रेन में बिल्कुल नहीं. मतलब I know who she was through. I think, but did you come for that scientific lectures जो DY में होने के?
Yeah. Internship में.
हाँ. Maybe once or twice वैसा. And Akram को I saw directly. I think when we were second year, हम लोग same classes में थे 12th में विद्यासागर में. और उसके बाद तो नहीं मिले.
11th, 12th. Yeah.
And then directly second year का just start हुआ. And I saw him. I'm like, because I didn't know कि वो भी BDS कर रहा है. Same year. But he was in Tena, I was in DY वैसा.
Oh.
And
So Vidyasagar, y'all might be knowing Shrivali, my friend. Tall, good.
I know Shrivali now. Kabhi ka yaad nahi.
She was also in
So
Vidyasagar.
I did crash course.
Achha.
I was doing Vidya Lankar before. Do engineering.
I think that's a different podcast. वो अपन विद्या लंकर और विद्या सागर का पूछेंगे तो हाँ मत.
Imagine I went to Agarwal and then it shut the next year. Stopped.
So that's how I met him. And then of course we used to meet beach में. And then he came to DY for ortho.
Yeah.
वैसा. Why did you choose orthodontics? Like, was it your first option?
So mainly in final year, I developed interest for ortho. Mainly because of biomechanics.
Okay.
But it is only when I took ortho I realized that ortho, what I was thinking BDS level and what is after MTS is completely different.
Okay.
But
like
my
what
liking towards biomechanics was always there.
But क्या different था? मतलब what you were thinking, like what
So,
you were expecting and क्या मिला actually?
Yeah, so basically in अपना final year they don't teach anything with respect to fixed braces.
Okay.
Whatever they teach is the removable appliances and preventive and interceptive orthodontics and those things, like basic things, like really basic. Majority of the clinical world, the clinical work what we're doing right now, that is everything we learn in masters.
Okay.
Uska gist is also not given in BDS level. So that is completely different. But yeah, biomechanics is there. The moment to force ratio, the couple, how the teeth will react to force. That got me interested for ortho. Like how will the teeth move if I put force below the crown level at the incisal edge.
So all this you were thinking in your undergrad days?
Yes. And
Okay,
then
wow.
biomechanics got me interested. I also got distinction in final year in ortho.
Wow.
So I was like, okay, out of all the other branches, I feel like the most likable subject for me was ortho. So I was like, let's do ortho.
So और कोई option नहीं था for you? It was just orthodontics, or you had a backup
a
option?
year before, I got oral surgery.
Okay.
So I was a little skeptical, like should I take or should I repeat the entrance?
Okay.
So I thought of repeating it. My second option was prosto.
Second backup option.
Only because like I would not get ortho. So something which gives me more revenue eventually or can make me like a good branch in dentistry. But favorite love was always ortho.
Since you joined and like when you entered ortho and now that you have passed out and it's almost been like 7 years now.
7 years.
What's been like your experience? Because for her it's different. She did BDS, then she worked a little bit for a couple of years and then she did MTS. And for you, it's different, right? Like after BDS,
I repeated for 2 years.
Yeah. So
Yeah.
but you were never into clinical dentistry, right?
No, I wasn't.
Like when you entered and now, what has been the experience like for ortho?
One thing is like ortho is a completely different branch. It takes you away from the general dentistry, which I somehow regret that I don't know a lot of things which I would be knowing as a general dentist today. But as per the ortho is concerned, in the past 7 years, it is drifting like drastically. Earlier, in 2017, 15, 17, you can say majority of the ortho practice was consultation practice, where every orthodontist is doing major consultation. But right now, it is more of, you can say every general dentist is doing aligners. Consultation is going down day by day. 50% patients are getting converted only for aligners. Braces, few people want to. So it's more of like a private practice now, where you keep giving the awareness what is important for braces, what is the case specifically for braces, specifically for aligners, and you're treating that.
Right.
So right now I feel personally that a private practice is more trending. It's more good with respect to ortho, correct ortho treatment for patients, compared to the consultation practice, what was earlier the core of the crux of ortho.
Because that's something which I had asked when she came for the podcast is, do you plan to put your own practice? So has your answer changed, Dr. Komal, or it's still the same?
No, I'm still a consultant mainly. But yeah, I do work with clinics where I can take my patients and things like that. That way there are various collaborative practices that are there, but otherwise I'm purely a consultant and I'm enjoying it as of now.
So no immediate plans to put your own practice?
Not immediately, no.
Okay. Like also now we have an orthodontist and a pediodontist. So as a general dentist, I wanted to ask, what is the common things between both of y'all? And if you guys, because on a daily basis, it's like a triad, like you could collaborate with the general dentist also, but an orthodontist and a pediodontist, how do you guys collaborate with each other regarding, say, preventive measures and maybe like diagnosis, treatment plan? So उसमें आप लोग सब लोग, like how do you guys, because since you all also work together, so can you please explain both of you?
So you want to say first?
Okay, so basically ortho and pedo do go very hand in hand.
Okay.
What happens is that child usually comes to us first at a younger age. So if we identify the root cause of a problem early on,
Right.
then we can take preventive measures so that later on in life, like the ortho treatment required can maybe be eliminated or can be at least reduced in the timeline or time structure.
Yeah. Patient might not require extraction eventually, maybe. So what I feel is, see, ortho has 3 branches ideally, okay? Like
Ortho.
Which is preventive, interceptive, and corrective orthodontics. Right? These are 3 parts. I feel preventive in India is completely with pedo. It is not with us.
Okay.
Because we don't get to see kids at the preventive stage.
Right.
That includes your space maintainers, your pit and fissure sealants, fluoride application, a lot of things. We come into the picture only when a pediodontist asks us to see their patients, or we have a kid in our clinic where we feel that, okay, after pedo, we are in constant consultation with the kid.
Right.
So ideally, a patient should see an orthodontist at the age of 7 to 8 years, 6 to 8 years, you can say, when the first permanent teeth erupts, so that we can encounter the problems. So there is an interceptive approach. The patient has a mouth breathing habit, thumb sucking habit. Patient sleeps with the mouth open. So these things we can address. Interceptive, you can say, it comes in both the branches. She can also correct, we can also correct,
Right.
and whoever sees it first should intercept the problem.
But would you love that? Would you love having patients a little early in your practice? Like when you say preventive, would you love them to come a little before to you, or it's okay if a pediodontist sees it and then it's different?
I think pedodontists are better with kids when it comes to handling them. So I would love that preventive is with them.
Okay.
We don't want it. I would love to see kid only when they are in a stage where I can handle them, around 8 years, 7-8 years. is where somewhere I feel like, okay, I can handle these kids now.
Right.
Because we are not taught how to do behavior shaping, behavior handling and all that, which they are trained in. That's their expertise, and I feel that should not be taken away from them. They should handle that. I want only interceptive and corrective.
Right. So, like, do you all go back and forth if you start a treatment of a kid who requires both, say, pediatric B and ortho B? So, आप लोग आगे like you'll go back and forth or first pediatric खत्म करेंगे then ortho में आता है and पूरा ortho करेंगे then like how do you guys go about like say managing a patient?
So supposing say a patient is 6 years or like 5 years of age.
Right.
Okay, and around 5 years there are no permanent teeth at all. There are only milk teeth. So at that stage, I'll see what the situation is. In case I feel that no, at a later stage he might still require a ortho, then I will just go ahead and get a ortho consult also.
Okay.
I'll ask him to at least see the child so that we have a comprehensive treatment plan and we are telling the parent from first, okay, bhai, we are doing something right now, but the permanent teeth have not come in, so we don't know how they are going to erupt. They may need something that time also.
Right.
So might as well if the parent has met both the doctors or like we have something that we can give to them.
Or at least we can educate them.
Yeah.
Like, okay, see, this is what is going wrong, and we are trying to put a spacement in and hold the space so that the future teeth comes at the right position.
Right.
So that the ortho treatment might get eliminated or reduced. The duration might get reduced, it gets simplified. So I feel that is very important.
Is this something जो आप लोग college में करते हो? Because for example, अगर if you're a clinician, how do you learn when to refer to, right?
Yeah.
So is this something that you learn in college that during MDS days that you all do that कि treatment चालू किए बच्चे का and then back and forth कर रहे हो या शायद से नहीं करते college में and then once you've passed out?
No, we do. Like I feel like, see, most of the ortho full-fledged corrective braces treatment happens when all the permanent teeth are in place. Okay. Now there are cases where we start early, which is more of like a myofunctional cases, the orthopedic cases where we are treating the bone rather than the teeth.
Right.
At that stage, we need pedo involvement. It could be to and fro based on, okay, before there is any pulpectomy which needs to be addressed, we need to save the tooth to act as a space maintainer. Or any of those things, we would refer to a pedodontist. Eventually, once, if the kid doesn't have any deciduous teeth, they're all permanent teeth, then we would require all the restorative, cleaning, everything at place to begin with our ortho.
Right.
So ortho comes in the last.
Okay.
There should be nothing because obviously hygiene.
So first पहले वो clear करना चाहिए पूरा.
वो clear करना चाहिए.
Okay. And then ideally that should be the thing.
Then that should be the case.
Say for example, as an orthodontist, what would you love for a pediatric dentist to do? Maybe in early diagnosis, like it's not a criticism but a feedback from an orthodontist.
Yeah.
What you would love to see from a pediodontist?
See, the most commonly cases what we are treating today is crowding. Okay. Crowding happens, many of the cases which mainly crowding happens because of early fall of the deciduous teeth. Now what happens is, you also know there is leeway space. The deciduous teeth is bulkier than the permanent teeth. So the excess space, it's completely in pediodontist's hand if they can save the space.
Achha.
Give a lingual arch or give a space maintainer to save the space. This is what I would really appreciate from a pediodontist who would save the spaces. Don't let the back teeth drift.
Okay.
If the teeth drifts mesially, we are in loss of space.
Yeah.
Our whole thing today, extracting IPR to correct the teeth, to align the teeth, is to gain space.
So all that can be avoided.
If
Definitely.
a pediodontist saves the space for us.
Provided the patient comes that early.
Dr.
Komal, to you, as a pediodontist, what would you like an orthodontist to ideally do for you?
Actually, kind of considering what he said, see, space maintenance and all, it's very, very important. The problem being most of the times is that when the parent comes to us, the child is either in pain. So what happens is that there are two options. Like sometimes if the tooth is salvageable, you can do a root canal or you can do an extraction.
Okay.
Extraction, we won't prefer, we'll try to be conservative. But depends on the parent finally. So in case you have to remove the tooth, they have to come back to us for preserving that space.
Space maintainer.
For that space maintainer. Many a times,
Do they come
the
back?
minute they don't, because what happens is the pain is gone.
Right.
Then they have disappeared. So we explain, but like the parents also need that kind of awareness and education. So that is one thing. And the second thing that is there, like for ortho, is I think there should be joint consults at around 6 to 7 years of age. If we do a joint consult, especially
both of you all are in the same room with the patient.
Yeah.
Okay.
Yeah. So that we can give like a treatment plan which both the doctors are on the same page with, or even if we come with different kind of ideas, at least we can give something that is a little like something that is going to give the parent and the child an idea about what their treatment is going to look like.
Okay, understood.
Mainly specifically for kids who have malaligned teeth or something like that, so that both the doctors are together doing a consultation.
And what's the most common feedback that you get from an orthodontist? According to you, like what's the most common thing which
common thing
they
I
complain
think
of
maybe what they complain of is sometimes what happens is many times what I've heard of many times crossbite correction. So crossbite is something that you correct the minute you see it. So if the child is very young, the pediodontist is going to see it, or a general dentist is going to see it, and the doctors think कि नहीं ortho होगा, braces लगेगा, and they let it be. But that is going
crossbite
to
can affect the entire growth.
Right.
A single tooth crossbite can affect the entire growth of the maxilla. Multiple teeth can entire growth of the maxilla. So these things you have to address as soon as you see it.
So that correction is very important at that stage. So many doctors miss it, or they don't do it, and because of which, like later on, the comprehensive ortho that is required
becomes complicated.
More complicated.
You can't really change a lot of things.
Anything which you think pediodontist can improve upon?
I feel
you face an issue with.
Honestly speaking, there is a natural bias in a specialty.
Right.
Okay, I look a case with an ortho perspective, they look at a case with a pedo perspective.
Right.
So what I feel is there are cases where a pediodontist might miss a habit, like the arch is narrow, or the patient there is mild crowding, So these are the things which I feel if a pediodontist can encounter earlier stage, it will be much helpful for orthodontist eventually. Breaking the habit is the major thing, because I have seen cases where the patient has been a mouth breather for life, and I see them at the age of 15, 16 years or 18 years where the arch is completely narrow, and now I can't do much. Like I can't really do any orthopedic treatment. Like I will just align the teeth or extract the teeth and do a what we say a camouflage treatment, but we cannot treat anything with respect to the jaw. So those things I feel if a pediodontist can encounter, provided the patient sees them, because there are many patients who don't see a doctor at all. So that is also very important. These are the things which I feel they should be a thorough checkup of everything.
I think both of you are saying is a long
awareness.
Term, like when you do a proper diagnosis and treatment planning, it should have a long-term planning. Just not like couple of years or relief from pain. It should be like maybe when she starts working, 5 years later, this or like he or she will have to go for a ortho treatment. So accordingly, make those changes during her visit itself.
Yes.
It also depends on a lot of awareness, because our parents, our Indian parents, most of the parents are like, okay, braces to bade okay lagta hai. They have that mentality कि अपने को वो change करना पड़ेगा. We have to change that mentality. We have to aware them that no, the beginning of a malocclusion starts as soon as the first permanent teeth erupt, which is at the age of 6 years, 7 years. One tooth coming in the wrong place can affect the entire growth. That awareness needs to be there. Parents को समझना चाहिए कि क्या जरूरी है.
So ideally क्या करना चाहिए आपके हिसाब से? Like we all say that everyone awareness communication करना चाहिए. But any practical tips from both of your side, what we can do to create awareness realistically?
I have few in my mind.
So basically creating awareness, like see, we've been doing dental camps and things like that, like going at school level and telling. So when parents come to know, or you show them, they do get an understanding about what is going to happen. Like he mentioned habits. So many times, when you look at the child only, if the teeth are very proclined or something, or you see their thumb, there might be a thick callus, so they are thumb sucking. You realize it immediately when you see it. The only thing is that then you have to motivate the parent. So motivation, now we have so many tools. We can use an intraoral camera. We can use, things like that, so that they understand actually what is happening. Because when we just say it to the parents, sometimes it doesn't hit where it has to. They will not take the enormity of it, or they will not understand how horrible it can be for the child later. So I think explaining, and now with the visual aids, if we explain, it will probably be more motivating to get that treatment done. So yeah, using a little bit of technology now that we have it is going to help for sure.
And indoor camera, like we both have done a camp in a rural place, and it worked. Like even if you don't speak the same language, if you show them, it's like that. I think that show do.
When we showed.
Yeah, so when you show them, when you make them aware, and
and not just the parents, kids, they were so aware, because what happens is now with the whole digital age, kids are also very like mobile friendly and very like screen friendly basically. Right. So when we showed them, they saw their teeth and they were like, we want to get treatment done.
Also, she gave out a prize for prevention when you show them, and whoever has the best teeth gets an award. So the next time you visit,
look forward
it's
to it.
motivating the child.
Gamify the whole. So you have many options in your head.
The awareness begins first. If you see on a large scale, it could be all these Colgate ads. They should start do a follow up with a dentist every 6 months.
Right, because they have a bigger reach.
Because they have a bigger reach. See, any dentist, they don't have so much capital where they can create awareness on a national level, which these people can. So I feel they should ideally start ads where they should promote, reach out to a dentist, ask your dentist, do a follow up. That is basic, I feel. Apart from that, again, these school camps are there. There are these awareness videos you can play in society lobbies, school TVs, and there could be ads before, any of these YouTube channels. There could be minor ads which the government can run. These awareness should be
mass
there.
Communication of
mass communication. Because I feel anything, most of the kids have reached to Instagram now, so you can make ads on Instagram or reels. Dentists can make minor reels, but it could, again, it should not be to promote a specific thing or a specific brand. It should be more like an awareness.
Yeah, that's a great point. Like for examtle, in Mumbai, on the PST bus, we see so many polio ke ads.
Exactly.
But I've never seen dental ke bare mein. Get a follow up done or early detection of caries. So if even if the government does it, like you said, it should
government or various organizations or
yes,
whatever, basically.
But they should.
There should be something.
So that
I feel even if government, I think majority of the kids, everyone uses toothbrush and paste.
Right.
So these toothpaste companies, at least they have a bigger reach and capital, so they should at least make some videos for awareness and government.
Or maybe hire movie stars.
Yeah.
I mean, if they are doing pan masala ads, they can of course do the ulta. They can do for better teeth cleaning. That was one. So any other options you have?
And then Instagram and Facebook and now YouTube videos.
There is something which I tell every dentist who I meet is start your own channels, start your own pages, because if
you never know, at least even if few people are aware, then they will tell their relatives, their kids, their family members. So we cannot understand the reach, right? So we should just keep doing as much as we can at our level.
Coming back to that point where y'all mentioned that y'all can do
joint consultation.
Yeah, a joint consultation where both of y'all are present. Any other things which you feel an orthodontist and a pediodontist can do?
I feel orthopedic appliances. Which is you can say the mandible is not growing well, or a bird face, or the maxilla is grown too much, or the middle face is not grown well. In those cases, of course, anterior crossbite is encountered by a pediodontist first.
Okay.
So they can collaborate with orthodontist and say that, let's intercept right now and do an orthopedic appliances to make changes in the bone level. Because that is a specific age window where we can do that.
Right.
Which is around 8 to 10 years, 7 to 8, 10 years, where we can do orthopedic changes. After that becomes more difficult. Guys mature later than girls even much younger. So I feel that is the point where a pediodontist involving an orthodontist will make a great treatment plan for a patient, for a kid.
Also, to some extent, what happens is that supposing we are starting a interceptive orthodontic treatment, what happens is the parent expects that it'll be done, whatever we do. So in case the orthodontist is involved, they'll at least know that maybe there is a second phase once all the permanent teeth erupt and braces will be there. Because sometimes otherwise in their mindset, they feel that we've already done some amount of ortho treatment. Why are we doing it again?
That awareness is not there. That also needs to be.
So if both the doctors are there,
they feel you out to fleece them.
Sometimes.
कि एक treatment खत्म हुआ तो दूसरा चालू करने बोले डॉक्टर.
So what happens is that, like, supposing say it's a class 3, matlab the mandible is growing more than the maxilla. Means the lower jaw is growing more. So we have to, that is the growth pattern for the child. So even if I treat it at a younger age, then too the growth is going to remain the same. So how much ever we try to restrict the growth and all of that at a young age, there may be little bit of ortho correction also required later on.
But I think you all should also have a connection, because the connection between both of you all is a general dentist.
Yes.
Right? Because a general dentist will always be present when you come or she comes.
Yeah.
So I feel like if you make a good triad, wherein a periodontist, an orthodontist and a general dentist, of course you all both have to have that tandem and collaborative efforts, but also if you add in a general dentist, might help out because
definitely
for better communication.
Definitely.
Because many times you are not there in the clinic. If as a consultant, I will not always be there to see the patient, but the general dentist will be doing regular checkups or regular follow-ups. So they might also notice changes and things like that. So they will obviously have to be in the loop,
right?
Or they will be forming the main part of the loop to keep that.
Many times general dentists bypass one of the specialities to save the cost, which is there. And it's fair because patients should also pay, right? We have patients who don't pay.
You feel a general dentist feels that bypassing one of the specialities, at least the treatment will be done.
Or part of the treatment you are eliminating. So what happens is that.
I feel like even if a general dentist bypass, I feel like every orthodontist and every pediodontist should consider the other specialities' importance at that specific age for that patient. If it's needed, please connect to your friend, your colleague, whoever you know in that branch and take an opinion, discuss the case.
Yeah.
We discuss case day in, day out. We don't charge our colleague, right?
Yeah, but I feel that happens when you put the patient at the forefront. That you want the best for the patient.
Yes.
A lot of times egos come in, which I feel is unnecessary because everyone will get to treat and the patient will get the ideal treatment.
So because what happens is sometimes the other person is coming in with a different perspective. You are supposing say we have read about the interceptive part or the primary teeth part, the growth stage, in a certain way. So I'll probably come with some different mindset or some different treatment plan that he has, then he might be thinking of, or that any other doctor might be thinking of. But if you are okay to bypass that and look beyond that and see, because sometimes when you get options, you might just be able to come up with the best solution.
Right. Has there been any time where you both have clashed over a patient maybe? I mean, not in a bad way, but
we have never. Clashed with a lot of periodontists.
No, but like she said, there are certain things which they know.
Yeah.
Have you all clashed ever?
We have never clashed.
No, we have not
clashed.
If you say you have never clashed, any reasons why?
If you ask me, I have different opinion with other periodontists, not with Komal, because I feel there are a lot of periodontists who does these initial braces treatment with respect to only front 4 incisors and molars, which is called as 2x4.
Okay.
In cases where I feel it's not required. But in those cases, there's a little bit of different opinion. Of course, at that point of time, they feel that is the best option. But I feel like it's not required. So, that in such cases, I was like, dude, why you did unnecessary braces? Because the kid has gone through the trauma of braces once, and then again after 2-3 years they're doing braces again. So I feel that of course you have to do 2x4 in cases where there is crossbite. I also feel a lot of periodontists, not Komal of course, who does myo brace and these T4K, these ready-made appliances, they just give it.
Right.
They have advantage, but I feel sometimes it is not necessary. Of course, they have knowledge about it. I'm not saying that, but I feel sometimes it's not necessary, which can be avoided. So like that little bit of different opinion happens.
By that I meant was what clicks between y'all. Like y'all are sorted on this aspect that if there's a pedo aspect, you give her full liberty, that you don't question her. You trust her completely, and because a lot of times, like I said, ego clashes. Even though you know she may be right, but then you can't just digest the fact that someone is like, or if she tries to correct you with her expertise.
Basically, what happens is that when there's a case, if I know that there is going to be some kind of a orthodontic treatment required, so I will always present my treatment plan, and I would prefer
There's
that
a healthy
he also
discussion
gives,
where we discuss what is best for the patient.
For the simple reason you're specialized in a certain field. Okay, like I've specialized in pediatric dentistry for 3 years, so I know a lot about pediatric dentistry. But ortho will be a part of it. Like we've learned only a part of it. Like they have specialized on orthodontics for 3 years.
Right.
So we have not done only orthodontics. We have done a lot of other things. So he will have his speciality and his expertise in the sense that he's done it for 3 years. So he's dealt with
that helps,
a variety of cases.
So we have a common thinking. So most of the times we have a healthy discussion with respect to cases. Of course, we respect each other's treatment plan also. There's a lot of respect since we have studied together in our UG level. So we know we are more friends than colleagues. So, we have that healthy discussion. He's like, so we can. Many of the times we can't really talk so openly when the pediatrician is not our friend. So sometimes that also makes a difference.
That's an interesting topic. A point, I'm sorry. So that you need to have that rapport with the person also.
With the person,
What if the person is a little more senior to us?
Yeah, we can't say that, your treatment plan is wrong according to... I can't say that, right?
Yeah.
To a senior periodontist, they might feel bad. So, since we are friends, I can say openly whatever I feel like. So, that is also one of the reasons I feel like...
So if you are an orthodontist or if you are a periodontist, you need to make a consultant your friend also. Not you guys, I'm saying, for a better...
It's better. See, because various clinics that you go to, different consultants come in.
Right.
So it's always good
and there are times where a same practice has multiple periodontists and a multiple orthodontists.
Definitely.
So, every clinic will not have the same consultant. So you will have to build a rapport with that doctor as well.
Right.
So that you can... Basically, it's for the better for the patient.
Because why I asked you is because, why don't you guys clash? Is I know a lot of people who are great clinicians. They have a bad rapport with other people, and they always keep clashing. So they keep changing their clinics as a consultant. And wherever they used to work earlier.
It happens with me also.
Okay.
There are a lot of clinics where a general dentist would interrupt and say that, I feel you should do this. Which I feel is not the best for the patient. And I say, sorry boss, we can't. So either we leave the consult or we lose the case or something.
Yeah, I think it's better to be transparent because there's a lot of times where as a general dentist, I make a plan, maybe regarding a kid or a person who requires ortho treatment, and that time where Komal comes in and says I can do this, but if you tell me to do this, I can't do it because it won't help the patient.
It won't help.
And if the treatment does not last,
I have been asked to put braces for kids who I feel like if you put it at the age of 9 years, the treatment duration will just prolong unnecessarily.
Right.
But just so that the patient doesn't run away.
That's very common. That's very
common that so the patient doesn't run away, the dentist would force you, let's just put the braces and start.
Right.
Which I feel is unnecessary because a treatment which you can do 2 years later in 2 years, you're doing it for 4 years, 2 years earlier. It doesn't make sense for me. So you rather wait.
In my hometown, I have seen ortho patients, their treatments are going on for 4 years now. 4 years.
Unnecessary.
And, when you ask the consultant who is doing the treatment, it's like the general dentist only because the patient refuses to pay.
Many times the consultant might even change because sometimes their career takes them a different way to a different city or a different location or something. Then the other consultant will have to go back to whatever treatment plan happened. Because
sometimes patient also doesn't turn up. You cannot blame only the consulting
dentist.
And,
of course.
There are a lot of reasons.
Yeah. I mean, the patient's not turning up and patients even
or breaking the brackets again and again.
That fact we are not counting only. That a lot of times even the patients are at fault. can't always fault the dentist.
Yeah, that is there. Many of the times dentists force to put the braces at an early age so the patient doesn't run away. I think we can avoid that.
Okay.
It's not necessary.
Regarding say ortho treatment and even pedo, when you all started and now, what changes have you all seen, both of you all? It may be the advancement in the digital dental aspect part. It can be new appliances.
With respect to ortho, there has been crazy advancement.
Okay.
We like in my you can say braces are reducing, aligners are coming up. Now there is aligners for kids in mixed dentition.
Is that because of aesthetics?
No,
I'm saying
aesthetics is
Yes.
aligners getting over metal braces.
Definitely. See, aesthetics, more than aesthetics, there are drawbacks of braces, right? People who are not able to maintain the hygiene well with braces, they develop cavities, hypomineralized enamel, decalcification, lot of gum issues, periodontal problems, lot of problems. These things are bypassed. The longer treatment duration, because braces works on one wire, so that is bypassed. Now with aligners, you can put every teeth at their respective position directly. So the treatment, it's more controlled, so it happens faster. More than that, it's lifestyle. There's no eating restrictions. You don't have to worry about hygiene. It's easier to maintain. So there are a lot of factors.
Less visits to the dentist.
Less visits to the dentist. But of course, one important factor is compliance.
Yeah.
You have to wear it.
Yeah.
That is more important.
Yeah.
But I have seen kids nowadays, they wear very religiously.
You mentioned pediatric aligners?
Yes, there are aligners for kids, for mixed dentition, early mixed dentition.
I've never heard of them.
So it's relatively new. It's very recently introduced, and so what happens is that kids are very motivated now. Like many kids that come
They
into the
want
Kids
aligners.
as young as?
like 7
years, 8 years.
Wow.
The minute you say he will require braces, they are like, no, I don't want braces, because their friends have now started wearing aligners.
Yeah.
Aligners with smiley stickers,
Yeah.
with
Yeah.
Avengers,
Yeah.
with all these.
So earlier that was with braces, because those colored
color bands.
elastics used
So
to come.
pediatric aligners is one.
Yes.
Have you all started doing treatments in that?
Yes, definitely.
Yes.
We are doing a lot of cases with aligners for kids. So advantage is, see, there are, as we did in braces, right? Like how a periodontist treats by 2x4 or a Catalan's appliance or single tooth crossbite correction or arch expansion with a removable appliance.
Right.
Those things are replaced by aligners now. So you do it again in 2 phases. There is first phase where you expand the arch and do minor alignment and you leave it. You create space for the permanent teeth to come. That is your first phase. Then again, when the kid reaches around 12, 13 years of age, where all the permanent teeth are in place, you do a second phase for minor corrections.
Right.
The advantage is you are gaining space. You're not letting the space go away. Crossbite is corrected. Arch expansion is achieved. Aligners do beautiful expansion because it covers the teeth from both the parts. Like braces are only from the outer part. Aligner covers the teeth completely. So expansion is very beautiful with aligners. So those things are much, much easier, and we're doing a lot of cases now. And
But I'm sure there might be some few disadvantages also.
The major disadvantage of aligners is
Compliance.
for mixed dentition is compliance.
Okay.
And the second disadvantage is as in when the permanent teeth falls off, the deciduous teeth falls off, the primary teeth, the aligner becomes loose. So you have to do a rescan and get more aligners. The aligner shape changes very quickly.
Okay.
So sometimes you lose the aligner tracking. Okay, the fit of the aligner gets spoiled early, but it's not a problem. You can do a scan, get more aligners, or call for new aligners, and then again it keeps changing faster. Like permanent teeth, you give like 10 sets and the patient is good. For kids, it's not like that. You need to have a close monitoring.
Yeah, but how has that changed your practice as a periodontist? Because like I said, if he's starting to close gaps, which a periodontist should have, so I mean, or you...
No, so these things also again same, like work in a little bit of collab.
Yeah.
So because at 6 years or like 5 years, usually a doctor or like even a general dentist usually calls in a periodontist for a consultation.
Okay.
So the minute we see that, okay, this is like a constricted arch, or there is no space, or there is like, space loss or something, it needs expansion. You can propose, instead of like expansion devices, you can now propose aligners because they also help with expansion very well.
Right.
So if we start doing it at that stage, or we've started cases where we've done it at that stage, the changes are so beautiful. The parent and the patient get very motivated. And then afterwards convincing them for a later on treatment is also very easy.
teeth.
Got it.
And it comes as a package, right? Like
Yeah.
you don't have to buy aligners twice. It comes as a package where you buy the first phase and the second phase is with it. A
It's just there's a
periodontist,
waiting
a
time.
collaboration with periodontist can fix these things very easily.
That's quite interesting actually.
Yeah.
I had no clue about them. But apart from those, what are the recent advances that you've seen in orthodontics?
With respect to ortho, see, the lingual braces have been completely replaced by aligners now. Scanning has come in. So, a lot of cases where I feel when the patient is younger, we can start doing scans and monitor. There is progress assessment, there is predictability testing. We can check the scan whenever we see the kid. Okay, now, for example, we see a kid at 7 years of age. We do a scan. We know the arch length, arch width and all of that. If the kid is like growing, we can do another scan every 6 months, 1 year.
So better tracking of it.
Better tracking. We can check how is the growth happening of the this. Of course, there are maturity index like lateral cephalogram for the C3, C4 vertebrae, hand X-rays to check if the chronological age and the skeletal growth is matching. So those things were always there. That in collaboration with these scans now. I mean, like earlier days, what we used to do is we used to take measurements, make mold out of it, and measure every tooth, right? If you remember in school, in college. But now what we do is we scan and we have it in seconds. So we don't have to, sometimes we get lazy, okay, we'll take impression and make mold again. No, we just keep doing scans and you have the entire record.
Right.
As the kid is growing, so that we know that, okay, the kid is growing sufficiently that there is enough space for the teeth to come. Of course, you can take an OPG and check what is the width, mesodistal width of that tooth.
Right.
The permanent tooth coming and how much space we have. So those things we can match and predict a better outcome in terms of this and reduce the treatment duration eventually for braces. I'm not saying it might completely remove the treatment. There are possibilities it may, but it will reduce the treatment drastically.
Yeah, like the analog system is still there, but the digital system has taken over completely. Anything which you're excited about the future of orthodontics? Some things which we don't know, or you want that to happen?
So I am excited about this something which is like the expander, what we use, the rapid maxillary expander. That they are coming up with aligners. That is something very interesting, which I'm excited about. It is coming up by one of the companies, but it is not still there in the market.
Okay.
So that expander basically works with RME. The problem with RME is it puts too much force and it is like food gets stuck and a lot of speech difficulties. So I think that expander with the aligner would solve that problem.
Okay.
Then there are like earlier days we used to use twin blocks. That has come in aligners now. We don't need to give twin blocks. Twin block is to push the mandible ahead, the lower jaw ahead.
So you can do that with an aligner?
With aligner.
Okay.
It is incorporated in the aligner.
Okay.
The blocks for twin block now, it's called mandibular advancement, MA. That mandibular advancement is now incorporated with the aligner. So I feel these advancement is helping ortho evolve drastically. And I'm pretty excited about it. It's good. It's good that the traditional things are getting replaced.
Anything which you feel like maybe a dream thing, but you want that to happen in orthodontics? You said about the expander, which is already happening.
It's happening, yeah.
But something which you feel should happen in the near future.
I feel I still, from my PG days till today, I'm trying to, I used to discuss this with my guides also, that like how can we reduce the treatment duration?
Okay.
Like drastic reduce the treatment duration. Now, of course, within the physiologic limit, that it's healthy for the patient. But I feel a lot of patients, they have this burnout, let it be aligners or braces. They have this burnout after a certain period of time, they don't want to do the treatment. They give up. Okay. So I feel like that is something which I look forward to, like, okay, some more advancement where we can move the teeth a little more faster, or something in which we can get a result a little more faster and reduce the treatment duration. Like right now also, there are treatment duration which is happening as early as 3 months, 4 months. But there are treatment which takes really long. Rotation, for that example. A rotated tooth takes really long to correct. So I feel like those things which we can reduce. And second most important thing is relapse. I want to make sure like how can we reduce relapse to a major extent.
Is that the most common thing which people come up to you?
Relapse is there. Relapse is there. You can't get away from it.
As a general dentist, that's the most common thing which I've heard from people is ortho किया था and then relapse हो गया या जैसे थे वैसे आ गए.
Yes, 100%.
Of course, we don't know the backstory क्यों relapse हुआ.
100%.
There must be a reason relapse हुआ रहेगा. Most of the time the patient does not wear the retainers that I've seen.
So retainer now, see, honestly speaking, this is one of the major problem I encounter in my practices. How do I tell the patient that I can't predict when the relapse will happen? Okay, I can't predict. No one can predict if the relapse will happen or no. Ideally, the protocol should be wear a retainer in the night for lifetime.
Lifetime?
For lifetime. So this is exactly the reaction we get from a patient. If we tell them that you have to wear a retainer for lifetime, in the night, only in the night. So I have seen cases relapsing after 7 years of retention.
Right.
8 years of retention. So we can't really predict if relapse will happen or no. What I suggest my patients is like keep wearing retainers every single night for a year. We'll do a follow-up.
And then we'll keep reducing it?
Keep reducing it. Like we'll do an alternate nighttime wear. Then we see if the retainer is getting tighter. If the retainer is getting tighter means relapse is happening. So again go back to everyday nighttime wear. So these are the things which I try out in my practice. But this is reality that no one can run away from relapse. Relapse is there and it is the biggest fear of any orthodontist.
When an orthodontist claims that 100% there won't be relapse, that's false, right?
That's
it
false.
can happen.
Of course it can happen.
It's
No
not
one's
in-
God, yeah. Every teeth can fall back to its original place. Not 100%, but 20%, 10%. How much ever you get a better bite, occlusion, whatever you do. Only thing which doesn't relapse is crossbite correction.
Right.
Because it's self-retaining.
But it's in your hands as how much relapse can happen also. So there are times where you might start a patient.
See, of course. There are these finishing goals. If you achieve all of them, the stability is much more increased. Okay, there is bodily movement. You can't do a space closure by tipping. These things, of course, you have to address. But in spite of achieving every single point, you can't get away from relapse.
Right.
I can't promise that there won't be any relapse if you don't wear the retainer. If you wear the retainer, then it's all good. It's maintained.
And Dr. Komal, for you, any advancements in pediatric dentistry which you look forward to?
There are various advancements that have occurred recently in terms of, say, anesthesia techniques and all of that. So, earlier the injection, even the bore of the injection that we used to use, like it's become much more thinner, slimmer, much more easier. Then now there are needleless injections that have come in. So these things are making, like, they are like kind of game changers in pediatric dentistry, because what the children were scared of or anxious about, mainly it's the injection.
Right.
That is kind of going away. So the minute you show them the injection without a needle, obviously, immediately that fear of that needle is only gone because it's not there. So things like that. And apart from that, technologically, there is VR glasses.
VR glasses?
VR glasses.
For the patient or you?
Yeah, as a distraction technique.
Okay, got it.
So, the kids will wear the VR glasses. They'll be in some other zone. They'll be watching something else, hearing something else.
Yeah, I've never thought about it.
Yeah, it is actually. It is a very, it's not very recent. It's been incorporated, but in India, it's not so common yet.
They'll take it home.
But I'm scared that if you're doing a treatment and what if they start moving?
No, then generally they wouldn't, but what we are eliminating is all the sounds of the drill, of the suction. Many times, that causes a lot of anxiety in children. So that all is eliminated. They have a sensory deficit from visual and hearing. So then you can easily do, and it's like studies have shown it's very good.
So the whole point is not to make them feel that a dental treatment
is even happening.
Okay. Any wishful thinking you have, like he had one where the treatment time will get reduced? So for you...
Yeah, maybe like anyways, there are a lot of advancement in materials and all. So things like even things like doing like basic dental fillings. Because what happens in children is that getting the child to sit for very long to do any kind of aesthetic filling or a composite filling also, it's very difficult, and you have to maintain that kind of you have to maintain that kind of field, that there is no saliva, there's nothing. So all of those things, if we can do, every kid, you can't even use a rubber dam. They will not be comfortable with it. They will not be compliant for it or cooperative with it. So, things like that, those kind of advances, if they are there, Now there are advances. There are sectional rubber dams also available. So these advances and incorporating them in our practice is what I'm looking forward to.
When we speak about the future, what do you think is the future aspect of collaboration between a periodontist and an orthodontist? Where do you see you guys collaborating?
Yeah, so I feel like
I think it's already happening quite a bit.
And a lot of clinics have. Like
many clinics
the
have.
The periodontist would ask for an ortho consultation at that particular time. Okay, let's have a joint consultation to improve the treatment plan, or discuss the plan at least.
Is there something which you have done?
We have done cases where we have discussed what is best for the patient at that particular time.
And the patients appreciate that? Like, what do you feel about it? Like,
I think definitely they do, because they get an opinion from both the specialities.
They are more like,
so they'll get a proper comprehensive plan.
Confident about the treatment.
What advice would you like to give for periodontist and an orthodontist? Someone's becoming a periodontist, become an orthodontist. So what advice would you like to give them? Like he or she is an intern right now, or have just passed out and has given the exam and wants to pick orthodontics. What advice would you like to give them?
See, earlier days what we used to do is have these ideal parameters, proper molar relation, proper jaw relation. Right now what we do is more face-driven orthodontics. Okay, what is good for that particular patient's face? He's chubby, he's thin. I feel the newer generation should focus more on that, on a face-driven orthodontics rather than those old angle classification. Nowadays there are a lot more scope with respect to non-extraction treatment. Utilize that. I feel with respect to all the colleges, like even in my curriculum of MTS, we were not really taught a lot about aligners per se, like how the software works. How can we make the teeth software works, like the aligner treatment planning basically. What I feel they should incorporate.
Right.
That's what I was discussing with my HOD also a few months back, that we feel that you should incorporate how to plan the aligner treatment, because we are still taught only about braces in colleges.
Right.
So we come out with only braces knowledge. So we feel aligners se hoga hi nahi.
And then either
but aisa kuch nahi hai. We can do it with aligners. There are a lot of cases which is advantage. We have an advantage with aligners compared to braces. So you treat it with aligners. But we should be taught about that in the curriculum, where we know that how to use the software, how to plan the case.
But then you end up being taught by the rep guys of
which I feel
companies.
is unfair, right? Because they would teach something, okay, we have this thing, we have that thing. See, the basic crux of biomechanics remains the same. You do it with braces, you do it with aligners. Now, only thing which I feel that all the colleges should start teaching is how to use that biomechanics in software. Knowledge is the same. You need to learn how to use the software, how to correct that using that biomechanics, which only an orthodontist can do, and an orthodontist should learn. I was working for 1 year with an aligner company where I have learned how to use the software in and out. Okay, more than a year I was working. So I'm very grateful for that exposure, where I know now how to use the software, how it works, what is overcorrection, how the aligner treatment works compared to the braces treatment. So this, I feel the newer generation is not getting that exposure. So I feel all the colleges should incorporate aligner software teaching thing.
Because otherwise you end up just listening to what the software guys tell you to do.
Following what the company is giving you the plan. You are seeing the plan. Okay, it looks nice. Let's go for it. You're not seeing how the teeth are moving. You're not seeing if there is space. You don't see anything. You don't know anything about the plan. That is what is happening. Majority of the orthodontists right now, they're doing aligners without any knowledge about the treatment planning.
Right.
Until and unless you
know
how to do
it. Colleges should start investing in
definitely
education of
definitely. That also includes that the college should have staff who is willing to teach. So they need to hire staff also who knows about the software.
Right.
Or at least there should be reps who teach the staff how to use the software, so that they can teach it or pass on to the students under them. That is very important. Apart from that, I also feel that don't lose touch with general dentistry. Basic touch with general dentistry is needed, which I regret today. I feel that sometimes we are in a position where we need some knowledge about general dentistry, or we need to work on some general dentistry stuff which we
Because
lose.
you guys end up doing such certain courses of general dentistry even after orthodontics just to get a hang of it, right?
We have to, because we lose touch, right? In 3 years, we don't do any fillings, we don't do any root canals, we don't do any extractions, we don't do nothing.
But I think that's the beauty of pediatrics, because they even
Pediatrics, everything is covered.
Yeah,
Everything.
they have to do it, so they never lose touch.
So they never lose touch. But in ortho, majority of the people lose touch. And tomorrow, when they open a practice, and if unfortunately there is a small thing which we have to do, and the treatment is on hold because of that, but we don't have a consultant, or the consultant is out of town, then you're stuck.
Right.
So I feel certain spaces don't lose touch with general, and don't run in this rat race of doing braces the cheapest, getting more consults. I feel that a newer generation should avoid. Try to open your own practice so that you can work freely.
Yeah, because I know a lot of orthodontists who don't have their own practice. They keep consulting to maybe 30-40 places in a month, which is crazy because you end up traveling so much. A lot of them now have started putting their own practices.
I feel
because you have a base where
I feel consulting is going to reduce eventually even more, as and when the aligner companies are reaching out to general dentists. All the top brands are reaching out. Majority of the minor cases are treated with aligners.
Right.
So I feel don't run behind consultation right now. Try to set up your own practice so you can work freely. You can do ethical practice, and you can do more of what you feel is right for that patient. So these are like my advances which I feel is important for the newer generation orthodontists.
Anything which you would like to add on, Dr. Komal?
If someone is taking up pediatric dentistry or something, like you said, it's all encompassing. So try to do as much as you can, like different cases, variety of cases. And what happens is every child is unique. So managing every child, because you need child psychology and behavior management tactics. So you have to do as many cases as possible. Give yourself as much exposure and experience, so that later when you have to face it alone in life, because in college you will have a lot of support. Later when you have to face it, you are ready for it. You are ready to go there and do it.
It should not be that you leave college and then you still have something to learn.
Yeah. You should learn as much as you can. Try to take up as much as you can. Do and those 3 years are pure clinical practice. So your clinical experience is what counts. So, it's very important that, you give yourself that.
And you need to like kids also.
Yeah, definitely.
You can't just take pediatrics
like
just
kids,
because
but
you want to do MDS.
Work on them is difficult.
Yeah. You can't just take pediatrics because you want to do MDS.
Yeah. Not just like kids, you have to be very patient.
Yeah.
Patience is one virtue you need to become a pediatric dentist. Otherwise, it will get very difficult.
Someone who has passed out now, what advice would you like to give them? Because since you have already have couple of years under your belt as a consultant, don't compromise on this. Like you said, don't cheapen the deal. Don't give cheap braces. So anything which you feel like as a consultant periodontist you should take care of when you visit a dentist.
So material that you use. Okay. I think you should never compromise on the material.
Should you carry your own material, or you should, whatever, after the understanding with the general dentist?
That is usually the understanding between the consultant and the dentist.
Yeah, but what if they don't keep the material what you want? So do you carry? You have
to carry. Most of the times we have to. Like now, supposing every general dentist does not have pediatric rotary files.
Okay.
But I would prefer using a pediatric rotary files over an adult file, because they are very specifically designed for a primary tooth. So, that kind of material, like don't compromise on it. Don't buy adult files or don't buy things, because it is going to be difficult for the child to open the mouth that much, or difficult for you to work. Most of the kids will not open so much. So those things you have to incorporate in your consult bag basically, and make sure that you have them. So never compromise on your material. And
then when you visit different dentists, like a lot of time, because they already must be having a set periodontist, right? That's what I tell a few of my juniors, like, never be sad with the rejection. What if they don't call you back? Of course. Because there are more dentists who will call you for work.
Of course.
Because the patients are increasing, the new dentists are increasing, new clinics are coming up.
So you should always take a chance wherever you get, no doubt. Like I have also met doctors and told them, introduced myself, and they have told me that like so and so pediatric dentist already comes. So very happily I tell them, yeah, you please continue. In case, in emergency is not available or something and you need someone, then let me
You'll
know.
have, yeah. This is possible in pedo. It's not
Have you
possible
fixed
in
it?
ortho.
Or did you just directly put your own practice, or did you, when you passed
Rejection?
out? No, not rejection, maybe. When you passed out,
Yeah.
you went to different dentists for
work.
as a consultant?
So when I had few friends of mine, seniors, who had their clinics, so they used to call me when I was a final year student itself.
Okay.
In ortho, that advantage is there because you can start working, because braces takes 1 year, 2 years to finish. So I had few clinics, but of course I had to visit multiple clinics, ask for work. You have to show. See, even if you're a good orthodontist or a bad orthodontist, until unless the people don't know you, how will you reach out to the that you have
basic
to go,
networking is required everywhere.
You have to.
You need to have good social skills also.
Yeah.
Sometimes
You can't just be an introvert,
you
because
can't.
even though you're a good clinician, but you are you refuse to go out and introduce
Yes,
yourself.
you can't do
because
that.
that's
You have
not
to.
something which is taught to us.
It is
In
not
colleges, you're taught to do dentistry. When you become a dentist, you are just not a dentist. You become an entrepreneur. You become because when you have your own practice,
You have to. It also, more than like a good clinician, you also need to know how well you can explain to the patient, how well of a communicator you are.
sometimes it's just down to that fact that
Communication
how
It's
do
only
you
communication.
Yeah.
Like I know so many practitioners who don't know good work, but they are very, very good communicators and they have a very good practice.
right?
Because see, at the end of the day, patient sees how confident you are and you have to gain their confidence. So they trust you. Of course, you have to do good work and everything at the end of the day, but there are many clinicians who are really good at work, but they're not able to communicate that well to the patient. So that is also, I think, very important. which
Any
we have
advice
to work on.
you have for just passed out orthodontist?
Get some knowledge about the softwares with respect to aligners.
Yeah.
Learn it. There are companies who are teaching it now. Or else you can join any other aligner company and learn the software. Get at least 6 months hang on how to aligner works, how the industry works, how the software works. That will help you. Like, I'm not asking them to start their own aligner company, but that will help you how the aligner treatment works, which we are not taught in MDS level. So that is something which I would advise all the orthodontists, especially passing out, learn it. It's very important. Very, very important, because tomorrow the practice again for braces is going to reduce drastically and the aligner practice is going to reduce drastically and the aligner practice is going to even more and behind everyone. So I feel learning the basic biomechanics with respect to software is very important for everyone right now.
And is it worth it becoming an orthodontist in 2025?
I feel it is.
Okay.
It is worth it. Even today, even tomorrow, and even after 5 years, I feel because prevalence of malocclusions in India is very high. Very high. And the population we have is crazy. So we'll always have patients. We'll
Right.
always have patients. That is no doubt. That be any part of dentistry, I feel we'll always have patients. It is only a matter of awareness, how aware the population is about getting the treatment done. That is what I feel is the lacking part.
But it also helps if you stand out from the rest. Like if you create a niche in whatever small way.
Yes,
Because there's so much of saturation which people talk about.
Definitely.
But at the same time, a lot of people and dentists are doing
good work.
Yeah, they're doing good, earning good. I mean, if I can ask you personally, what do you feel? What helps you stand out from other orthodontists, or what has been your approach towards dentistry, which helps you
So
get?
see, the most important thing is, as and when you start your practice, our mind should not run behind money. That is my first criteria, because
But that is where it goes, like because अभी इतना साल पढ़ाई की है ना.
हाँ, but अगर आप सिर्फ पैसे के बारे में सोचोगे, then you will cut down on your material cost. You'll use cheap materials, so you'll have a bad result. I feel you don't go down on your materials. Don't cut down there. Use good materials. Use good company aligners, which you feel has evidence. Most important thing is you do good work.
Right.
Be loyal and ethical to your practice. It's okay if you do 10 less patients, but if you do good work, they're going to get you more patients for sure. That is two major things what I feel is very, very important. And I feel is, don't just, even for consultation, don't agree to do a compromise result just because dentist is forcing you to do it or you don't want to lose the patient. Don't do it.
It's not worth the headache.
It's not worth the headache. After 1 year, 2 years, the patient's going to sit at your head. they want to do bad publicity for you, that okay, you said this will happen, now this is not happening. Now they will not remember the conversation we had 1.5 years ago. No one will remember that. And then don't do that. Like, stick to your treatment plan. If you are confident, stick to your treatment plan and don't do the case.
That's
so
what you have been doing also.
This is what I have been doing.
And it works for you.
It works for me.
Okay.
It works for me. Today I have more referral practice than new patients because I have done good work for so far. Like, I'm treating kid, the sister, now mother. You know?
Yeah, so it's like you build a rapport
exactly
with the patients. You build a good catalog and an image where people trust you and your work.
Exactly.
And Dr. Komal, what has worked for you as a clinician? What helps you stand out from so many pediatric dentists? What do you feel has worked for you?
One thing that really helped me was that break that I took between my BDS and MDS. So I was like doing general dentistry for almost 3.5 years.
After BDS.
And then I went into MDS. So
you did not directly jump into...
I didn't directly jump. So one thing that really helped me was that I got a lot of hands-on experience and a lot of clinical experience. So I already had that when I got into it, and because of which my guide and my HOD, she was very okay with letting me start early into clinics also. So I got experience in pediatric dentistry also early on because of which. So that helped. And second thing, that a lot of my colleagues and a lot of my friends, like even Dr. Akram, he had set up his practice by the time I was done.
Right.
So immediately I started getting consults also. I started getting like work also, because by the time I got done, they were all settling and opening up practices. Work-wise also, that really helped.
Right.
So both ways, I think, it worked out.
Yeah, that's a good point. Like, take a break, learn everything. But like I said, that can't be applicable to him. Like orthodontics. Like you can't take a break and do clinical dentistry and then go into orthodontics.
No, it was helpful in pediatric because it is a little bit of everything.
Ortho is completely different.
Yeah.
So we come to our last part, is basically you guys know each other since 2009.
Yeah.
2009.
Yeah,
First
2009.
year. You all have done BDS together. MDS, of course, different colleges, but almost same areas. And then now you all are working together in different practices. How do you think dentistry has changed when you started? And looking back, do you think it was worth it?
Definitely worth it.
Worth it,
yeah.
Right now we have just the latest things are like scanners and aligners and material wise. That's all. That the crux of the any dentistry remains the same, right? Like for ortho, it's biomechanics, which is basic because our human anatomy is never going to change, right? How much of advancement we get. So the crux is the same. Biomechanics is same. Ortho remains the same. We just have more and more tools to incorporate in our practice, which will make our life easy and patients' treatment duration lesser or easier. Apart from that, I feel everything is the same.
In terms of pediatrics, like supposing fillings, as simple as cavities. Now, your principle is the same, that cavity nikalna hai, but your method, your technology, your everything, like your material. Earlier, it was like, you will prepare the tooth in a certain way so that wo filling nikal nahi jayega. But now now our concept has changed. Like you are not preparing so that it does not come off, because the materials are more adhesive. They are more advanced. They will stay. Now you are being more conservative. You are reducing the amount of tooth structure that you are removing.
Yeah.
You are conserving the tooth structure. So you are trying to make sure that, because the material has advanced. So there's a lot of difference. Like we used to do silver fillings back then. Now you don't touch silver fillings.
Like looking back, like, who would have thought, like, because I think it's you put in a lot of working hours that helps.
Yeah.
Like you said, minimal invasive. New tools have come in. And why I asked you that question is a lot of people come up to me and ask, like, should we do dentistry or no? Even if you do some other branch, some other career, there will always be saturation. There will always be competition.
Every field is saturated.
And dentistry will never be like not saturated.
No, saturation is definitely there. You just need to know how you are making your mark, or you just need to basically do very good work. So your work speaks for you, and then you do well.
Yeah, and you need a lot of patience.
You need patience.
A lot of
you
patience.
need to be loyal. You need to do ethical practice, and you need to do good work. These are basic things. Nowadays, one extra thing is added is you should know how to market yourself.
Yeah.
Oh yeah.
Marketing
I mean,
Instagram
even
presence.
if you know the best of the best procedures, and if you can't market right,
yourself, that is very important. Now we need to know how to market ourselves.
How do you plan to?
Yeah, hopefully this podcast.
So I tell everyone this, like, of course.
Making Instagram reels, putting
Even
stories.
though you don't like to, but then you
I
have
don't like to. Honestly, I hate making reels, but I do. I have to. Social media presence is something which is very important now.
I saw your reel, which you offer trending topic where you go and touch the black and white to a colored image, like the before and the after.
Yeah.
I
So I've been making reels.
I was
now.
like, good, Akram kar raha hai marketing.
You have to.
Yeah, you have to. Of course, it's great.
See, either you hire a company who does for you and you pay a lot of money. If you can't afford that, then you have to do it. But even whoever does it, the dentist has to be involved in it. And I feel it is important right now because awareness is. Earlier days, the patients were very loyal to their family dentist. They should not go anywhere else. Currently, that is not the situation. It has changed. Now patients are not very loyal to the dentist. They switch very easily. They are more aware about the specialities, so they know who to go to for that specific thing. They know how to go to an endodontist. They need to go to a pedodontist, orthodontist. They know that. So I feel like that awareness needs to be there. Social media presence needs to be there. Everyone needs to have that presence until and unless you have enough patients that you don't want more patients. Then you don't do these things. But I feel that is important.
Fun fact, Dr. Komal started her page 2 years back and she's still posting it. Like she's yet to post. She just keeps reposting the old videos. I was like,
I've never seen her reel though.
She will.
I have
I think after this podcast she will.
Yeah, so I have been pushed by Dr. Arib, by Dr. Akram, a lot of, actually almost everyone, but I am not. I'm more of a repost person than a post person.
Yeah, but like you said, otherwise you'll have to hire someone.
Yeah.
And if you do that, you'll have to act a certain way.
Yeah.
But if you do it yourself, you can just be yourself.
Yeah. No, yes, it's definitely something that...
And that's something which a lot of new dental students and people coming up should know, that you have to market yourself.
You have
No, I mean...
Not just that, then so sometimes, when job requirements for associate dentists, I have seen that someone has mentioned that like a little bit of social media knowledge, editing reels, etc. is a job requirement for a new dentist now.
Even in UAE, a lot of my friends who are working there, they are like, dude, your Instagram profile will get you a job in UAE. They see how many followers you have,
right?
How bigger work. They see their work.
But I think that even the patient sees.
They see.
अगर इसके ज़्यादा followers है,
that's
how the world works right now.
Before after pictures, these things are making a lot of difference right now. A lot of difference.
I mean, that's how the world works, sadly, because the generation before us did not had to do all this.
All these things.
But the current generation, the one coming up, have to do it.
The next generation might have something else.
Yeah.
Yeah.
So you never know.
No, very soon there might even be a course like Instagram marketing or digital marketing.
Yeah,
they have already. I feel like digital marketing.
Yeah, I think what she's referring to is making like trendy reels for as dentist.
Yeah, for dentists also. I mean, it is there in every field, but this cost and cooperation might also occur.
What's been your both journey as individuals? Like, you all know each other almost 15 years now. And what do you think about how his journey has been, and what do you feel how her journey has been till now?
I think it's very admirable. Like, seeing your colleague grow is
definitely
something that's really good. And yeah, we've worked together, so I know how well he works and work ethic.
Komal is a very good pedodontist.
Let her compliment you. You interrupted her. Let her compliment you.
No, so it comes across, right? I myself got my aligners done with him. So I think being a dentist, I trust him that much that I got my treatment. So yeah,
definitely. And I also feel like as a pedodontist, Komal has been working in my clinic from the beginning. So I have seen her treating cases where a 2-year-old, 1.5-year-old, who's even consultation I could not do. So hats off to her, the way she handles the kid. There is not even one single patient in where we have failed, we was not able to do the, the procedure, or, we needed nitrous oxide or GA or conscious sedation. We have always done on the chair very comfortably. Kids love her. So I feel like she is the best.
Yeah, so like you said, dentistry works provided you do the right way.
You do the right way.
Any advice you would like, parting advices you would like to give people who want to make, say, dentistry their career? People keep asking me, and I said the best ways I can ask other people from different branches and different people, their experiences, that if given a chance, would you become a dentist again?
Yeah, definitely. If you would have asked me this question in 2016-17 when I was preparing for my masters, I would be like, maybe not. But today, after doing MDS in ortho and having a successful practice and ortho consultation, I would be like, yeah. Like right now, I would choose ortho.
It's worth it.
It's worth it. What I would like, last advice I would suggest is like, if you don't belong to if people come to Mumbai to study, like if you're not from that city, don't try to like settle here. Try to go to a second tier city or your hometown where you know people.
Right.
It's easier to set up practice around an area where you know everyone compared to in completely new area to gain the trust of the patient. It's a little easier. So I feel like
More expensive also.
more expensive.
There's saturation.
Definitely, there's saturation. What most of the people think, that okay, like this area is, like all good crowd stays here. So, the clinic will make good money. It is not true. Those areas are the worst areas to put up a clinic. I feel 2-tier cities, smaller hometowns, these are the best places to put the clinic right now because patients are a lot many and the clinics are very few.
Yeah.
Provided if I would have got a chance, I would have. Now I had to
You
open
still
in
can. You can open a second one.
Second one. I had to open in Santa Cruz because like I'm born and brought up there.
Given
I
your
know
profile, I
everyone
think
there.
you should put one in Goa.
Go on.
I know a lot of orthodontists who put in one. They have in Bombay or Pune and one in Goa.
Yeah.
I know 6 of them. I
Yeah.
think so.
Yeah, I feel that definitely makes more sense, like I feel because it's lesser competition and you're doing good work and then more crowd, there's no competition, so you don't have to worry about that. So I think it's easier. So that is very important.
Like a huge population of India does not stay in the cities.
Yeah.
It is actually in the other pockets of India. So, and it's not fair to them that they are not getting good dentistry. Only city people, like there are a lot of dentists who are doing good work in city, but you need dentists who are doing good work in the second tier, third tier, or the small towns. So
that's what me and Dr. Komal are trying to do.
Yeah.
So I mean,
you told me that's very good
because
thing,
instead of them coming to Bombay, like imagine for one OPG you have to travel 100 kilometers.
Yeah.
So instead of that, why don't we as dentists take good dentistry to them?
yeah.
Exactly.
And they are very appreciative of that.
Yeah. Like a lot of newer dentists, they'll feel like, oh, of course, he will say that only because his clinic is in the city. But that is not true. The reason is like I was born and brought up here. Otherwise, if I would have had a chance, I would open somewhere in interiors.
Yeah.
It also depends on that,
I know so many dentists who have shifted from Bombay, Pune to a lot of tier 3, tier 4, even villages.
Yeah.
And their
practice
doing good.
is crazy.
Yeah.
Their
Crazy is
crazy. Understatement, 100%.
It is
100%.
Yeah, I mean that camp also that we'd done, we'd seen around 200-250 kids. And
in a day.
And only one kid had got some kind of dental work done. So out of 250, the awareness is so less and like your scope of work, like if you tell them and you show them, they are ready to get it done, but they don't have the means for it. They don't have the setup for it.
That's what even I felt like you have to practice. Because since you've studied in DY, you have to be in Bombay and practice here only. But as you start aging and as you start meeting people, traveling
definitely.
more, you start realizing it's not true.
It's not true at all.
At the end, you do good.
Like after 10 years, you only would want to run away from the city.
10 years is too much.
Yeah, 5 years you can say. Yeah, run away and the more peaceful place,
Of course, certain lifestyle things.
It is, it matters, but again,
But it matters to an age. After that, it does not matter.
It does
how
not.
many, personally, we used to go to a lot of cafes now. I mean, how many cafes do you go now? You don't get the time.
Nothing.
So it does not matter. So it was great having both of you all on the podcast.
Thank you for having us.
It was almost like an intro thing about because when Komal told me that there's a thing called Paediatrics and interceptive orthodontics and how both specialties collaborate together, work together. I was like, we need to have a podcast where at least the intro part and the basics part, we need to expand and at least show people that there's something like this.
Yeah.
You guys know it. We didn't know
definitely. Everyone, I feel, keep the ego aside. And
Of course.
and
It
it's
helps
always
everyone.
learning from other specialities and giving, it always help to grow.
Right.
Definitely. I think all specialities like should work hand in hand,
Hand in hand.
because then you can give the best on to the patient.
Sometimes
and-
even if you know, you miss out, but just because you don't have that vision and that someone else can point it out for you,
Yeah.
so that will definitely help. That will definitely help.
Perfect. So thank you guys
Thank you
for
so
being
much.
on the podcast. We'll again have you all soon on different aspects, or maybe pick a topic and expand more on that, because a lot of things you all said require a lot more time to talk, to go in depth upon. But like I said, it was great. At least people who want to join orthodontics or pediatrics, it might help them. And,
I hope so.
I hope-
Hopefully, yeah.
yeah, of course. You guys should tell me after a few weeks when the podcast is out if people have, because whenever the podcast is out, they get the guest who comes on the podcast get a lot of DMs asking about. So I think you should be ready for that. she's already been.
She's been
Yeah.
the frequent one.
Yeah. So again, we'll have you.
Thank you so much.
Thank you so much.
Thank you.
We'll see you all soon. Okay.
Yes.
Thank you. It's called. She'll take a 10-second video.
Call.
Ma'am,